Ayan. So, good evening everyone. So, I will be discussing phakic IOL implantation and laser vision correction in patients who are actually eligible for both. So, this is my financial disclosure. So, first things first, now we have to remember that phakic IOL implantation and laser vision correction are considered forms of refractive surgery. As such, a good outcome starts with good preoperative screening and adequate chair time. For this talk, the phakic IOL being referred to is the Vision ICL, mainly because it's the only phakic IOL that I am using. So these are the standard or routine pre-op screening that is done to patients undergoing refractive surgery. So out of all those, the important thing to me to really first check is the anterior chamber depth. Kumbaga, that's the first thing that I will look up because this is make or break. If the anterior chamber depth is less than 2.8 millimeter, that automatically disqualifies the patients from phakic IOL, so there's nothing much to discuss anymore. So this is my personal decision-making tree. So I first look at the ACD. As I mentioned, if it's equal to or more than 2.8 millimeter, I offer the patient the ICL. However, if it's less than 2.8 millimeter, I then next check the refraction. Generally speaking, my cutoff is about 9 diopters. If it's more than that, I tell the patient na they'll just have to continue wearing their contact lenses or spectacles. Very rarely, I might entertain doing PRK on these patients. However, for less than 9 diopters, I next look at the corneal thickness. If the corneal thickness is less than 500, but the corneal topography is normal, then patient would probably benefit from PRK. However, if there are any abnormalities on the corneal tomography or the topography, I'd probably just tell the patient it's safer to continue using contact lenses and spectacles and not undergo any forms of surgery. If the patient has a corneal thickness of equal or more than 500 with a normal corneal tomography or topography results, then LASIK will be a good option for this patient. However, if anything is abnormal, then I'd try to be more conservative and not do any surgical procedures. Generally speaking, I'm not a big fan of refractive lens exchange because of the risk of retinal detachment, which can have a blinding impact on the patient. So once I've deemed that the patient is eligible for the Vision ICL, so these are the advantages that I point out to them. First of all, it's reversible. Down the line, if there are other new procedure that the patient would wish to undergo, the ICL can be easily removed and the patient can undergo another procedure. The material itself has UV blocker, so that actually is a bonus because once the blocker can help also minimize the incidence of cataract formation in the future as the patient grows older. There is definitely less incidence of dry eye syndrome compared to LASIK, and that's been substantiated by numerous studies. Overall, as Dr. Ang mentioned, the ICL really offers very good quality of vision with very minimal disturbing night vision issues. It's also safer for patients who will most likely be susceptible to any corneal ectasia after laser vision correction. Furthermore, some studies do show that there may be less regression, especially for those with moderate to high myopia, and it makes it possible for patients to have multifocal IOLs in the future when they do undergo cataract surgery, mainly because the curvature of the cornea is unchanged. And again, as I mentioned earlier, compared to refractive lens exchange, the risk of RD in ICL is very negligible. Of course, I also need to explain what are the potential disadvantages after the surgery. My number one worry is still overvaulting. And depending on the situation of the patient, if it's causing like increased IOP, then an exchange of smaller size may be needed. There have been patients with increased IOP due to inflammation or steroid response, and there may be residual error of refraction, especially for toric ICLs that may have inadvertently rotated. Previously, cataract formation was a concern, but with the central flow nowadays of the new, this has been minimized. Infection, particularly endophthalmitis, is actually estimated to be just 1 in 6,000, definitely less than what you would expect after phacoemulsification. And realistically speaking, no, in this day and age, no, cost sometimes still is a major factor in the decision making of whether to have phakic IOL versus laser vision correction. So I'll just show a couple of cases. No? This is a 24-year-old female with manifest refraction of minus 675 combined with minus 125 axis 80 on the right, and on the left it is minus 8.25 combined with 0.75 at axis 80. And as you look at the ACD, the pachymetry, all of these are actually within normal. In fact, the pachymetry is very thick, and patient would have been eligible also for laser vision correction. However, after much discussion, patient opted for the ICL. So this is the corneal tomography. No? Just shows that everything is normal. No? At 1 month post-op, no, uncorrected visual acuity is 20/25 on both eyes. The patient did have minus 1 diopter residual on both eyes, but the main reason for this is that patient opted not to have a toric ICL, so hence the residual astigmatism. Vaulting on this patient is approximately 1x, or as Dr. Bobby Ang mentioned, ideally it has to be 0.25 to 0.75. So she's within the normal range. This is a second case, again, of a 24-year-old female. This is one of my earliest ICL patients. No? Her refraction on the right eye is minus 650 combined with minus 2.25, axis 175. And on the left, it's minus 6 combined with minus 275, axis 5. And again, her other parameters are normal. So this is her corneal tomography, and then no, everything is normal. No. At 1 month post-op, the right eye achieved 20/20, but the left eye was 20/30, mainly because there is a residual error of minus 1.75 astigmatism, axis 45, and when I dilated her eye, I noticed that the axis was off by around maybe 10 degrees. This was one of my first toric ICL, and at the time I was just using a manual toric marker, using like the marker. However, when I discussed the possibility of doing another surgery just to rotate again the ICL, the patient opted not to because she said she was already very happy with her quality of vision and felt na it didn't really warrant further intervention. So I'll just show you a edited video of my case or how I do the ICL implantation. Sorry. There. Couldn't find the cursor for a while. See? So I generally make a slightly large side port compared to what I would with a phaco because our tucker seems to be on the thick side. I inject viscoelastic, making sure not to overfill. So I make sure that there are still swirls or I still see swirls. We use a 3.2 millimeter mani knife, which we find because it's much more smoother than other brands. And I tend to inject the lens very, very slowly, making sure that I actually see the orientation of the foot plates and to make sure that the orientation marks are in the right position. I also want to make sure that the three holes are aligned to make sure that the ICL will open properly. And the last thing I want is for the ICL to flip inside the eye. I always tell the residents that it's not like a sprint, so that you have to do everything very fast. So I inject viscoelastic on top of the ICL just to give me a bit more space. And then I just slide it in. I normally start with the trailing haptic first. And a very dilated eye really helps a lot. So a bit more viscoelastic. And then I tend to do a cross cornea technique when I tuck in the leading haptics. It's just easier than going on both sides. We now use a markerless system for orienting the toric ICL. It makes life easier. And I feel that it is more accurate than the manual toric markers. So once I'm comfortable or I'm happy with the position, I do passive evacuation of the viscoelastic with a 5 cc syringe and a cannula, about approximately 10 to 15 ml of BSS to flush out the viscoelastic seems to be adequate for me. And we can also evacuate using the side port. Once that is done, I recheck alignment to make sure that everything is in place and that I did not inadvertently rotate the ICL while flushing. So I deepen the chamber just a tiny bit. And sometimes I hydrate the side port, but most of the time it's not necessary to hydrate the side port or the main port because you don't really stretch the edges, so there's really very minimal leaking. Okay, and that's it. So thank you very much again to PAO and PSCRS for inviting me to share my experience.